Welcome to the deep dive, where we take your curiosity and hopefully transform it into expertise.
That's the goal.
Today, we're embarking on a journey into a topic that, well, it might seem deceptively simple on the surface, but is, in fact, incredibly complex and utterly vital.
Absolutely vital.
We're talking emergency medicine and surgery here. The intricate world of shock, electrolytes, and fluid management.
Yeah.
You might imagine managing a patient's fluid levels is, a straightforward task. But as we'll uncover, it's actually one of the most profound and frankly challenging responsibilities surgeons face, day in, day out.
Indeed. And this deep dive, it's really designed for those who truly want to master this information. To understand it with the precision and depth of the elite professionals in the field,
Right.
we're drawing heavily from a leading surgical textbook, a source that, humbly acknowledges how much we've learned, often through, painful historical lessons, and yet how much we still don't fully comprehend about the human body's astonishing dynamic ability to regulate and compensate. Our current knowledge, in many ways, it remains surprisingly elementary. It's a
Yeah.
testament to the body's enduring mysteries, really.
That's a crucial point. We're going to journey from the very earliest, almost unbelievable attempts at resuscitation,
Some truly wild stories there.
tracing the evolution of our understanding of shock, and then delving into the cutting-edge research that's striving to revolutionize how we manage critically ill patients today.
Yeah, the stuff that's happening right now.
So if you're ready to immerse yourself in the fascinating, and let's be honest, often paradoxical fluid dynamics of the human body, let's truly unpack this. The foundation. Why surgeons are masters of fluids in the historical context. To begin, why are surgeons specifically considered masters of fluids? It sounds like it's far more involved than simply knowing a few IV drip rates, right?
Absolutely.
What makes this area their unique domain?
That's a great question, and it really gets to the heart of their unique challenge. The depth of a surgeon's responsibility here is immense. Why? Because they care for patients who, for various critical reasons, simply cannot eat or drink.
Okay.
Think about it. A patient suffering from severe hemorrhage, massive bleeding, or one recovering from a major surgery, or even someone losing significant fluid from drains or large wounds.
Right.
Patients quite literally put their lives in a surgeon's hands, and managing their fluid balance isn't just some side task. It's foundational. It's the bedrock for every other aspect of their recovery and their ability to heal.
And this isn't a static problem, is it? You can't just set a drip rate and walk away expecting it to hold constant.
Not even close. The human body is an incredibly dynamic system. It's constantly adapting, constantly changing. A patient's fluid status is in continuous flux due to, a myriad of factors. You've got ongoing bleeding, maybe systemic infections like sepsis kicking in, neuroendocrine disturbances that throw off the body's natural regulators, or even dysfunctional regulatory systems within the body itself that might just be struggling to respond properly.
Okay.
So when fluid management is handled well, it provides that critical stability, that physiological bedrock, if you will, needed for surgeons to then effectively address other life-saving aspects of care,
Such as?
such as providing proper nutrition, administering potent antibiotics, draining stubborn abscesses, or treating areas of ischemia where blood flow is restricted. You need that stable base first.
So, distinguishing between conditions that might present similarly, like, say, simple dehydration versus anemia,
Right.
or active hemorrhage versus even the dangers of over-resuscitation, that must be absolutely vital for them. What are the key nuances they're constantly navigating there?
Precisely. Each of those conditions, while they all involve fluid dynamics, requires a distinctly different approach. A patient might look dry, appear to need fluids, but the underlying issue could actually be anemia, a lack of red blood cells, not pure volume depletion.
Okay, different problem entirely.
Totally different problem. Or they might be actively bleeding, needing blood products, not just, bags of saline. And then there's that paradox of over-resuscitation, where too much fluid can be just as detrimental, maybe even more so sometimes than too little.
How so?
Well, it can lead to complications like pulmonary edema fluid in the lungs, or abdominal compartment syndrome, where pressure builds up dangerously inside the abdomen. So it demands constant, nuanced assessment and, crucially, adaptation.
When we talk about fluids in the body, we're primarily talking about water, which of course makes up most of our body weight. But where does all this water actually reside? How is it compartmentalized?
Right, it's mostly water. And it primarily resides in Three interconnected spaces. It's important to kind of visualize these. First, you have the intracellular space. That's the fluid inside our cells.
Okay.
That makes up the largest volume, about 2/3 of our total body water. It's where most of the critical cellular machinery operates. Then there's the intravascular space. That's the fluid within our blood vessels, essentially our blood plasma. That's the circulating volume.
The pipes, basically.
The pipes, yeah. And finally, you have the interstitial or third space. That's the fluid that bathes our cells and tissues, sitting between the cells and outside the blood vessels.
The packing material.
Sort of, yeah. And water is constantly dynamically moving between these compartments, influenced by osmotic pressures, hydrostatic pressures. It's a constant balancing act.
And what's particularly crucial for a surgeon when considering these three compartments in a patient who's, say, critically ill?
What's absolutely crucial, the key takeaway here, is that the intravascular space, blood vessels, is the only one that surgeons have direct and immediate access to. When they insert an IV line and administer fluids, they are directly impacting the fluid volume within those blood vessels. Managing the fluid within that space is their most direct lever to influence and stabilize the fluid levels in the other two compartments.
So that's how they rapidly address, like, circulatory collapse or make sure vital organs are getting perfused.
Exactly. It's their main handle on the system.
Our sources really emphasize the importance of history here, not just for, fascinating anecdotes, but as a critical component for understanding modern fluid management. Why is it so essential for clinicians to look back in time?
It's absolutely vital, and for several really profound reasons. First, understanding history helps us truly see how medical knowledge evolved over time. You grasp the context of current practices, appreciate the journey of discovery.
Right.
But more importantly, it helps us identify and hopefully avoid repeating the errors of the past. Our sources explicitly state something that really stuck with me. While we might be awed by past discoveries, we should be equally astounded by how frequently we were wrong.
That's a sobering thought.
It is. It's a stark reminder that what seems like established dogma today might be viewed very, very differently tomorrow.
So you're suggesting future surgeons will undoubtedly look back at our current body of knowledge and feel the same way, amazed at how little we knew and how often we were mistaken.
Exactly. And that perspective, it encourages us to constantly challenge current dogma, even if it feels deeply established. It's an invitation for continuous critical inquiry.
Keeps you humble.
Absolutely. We need to continuously assess, what experiments were done, what wasn't done, and crucially acknowledge that our current understanding of shock, this state of profound physiological distress, remains, in many ways, surprisingly elementary. History teaches us humility and the absolute necessity of ongoing scientific rigor.
Okay, this next part is where the history truly gets captivating and surprisingly dramatic. Tell us about the miraculous deliverance of Anne Green. It genuinely sounds like something straight out of a historical novel.
It truly does. It's one of the earliest authenticated resuscitations in medical literature. It involves a woman named Anne Green who was executed by hanging in Oxford. This was December 14th, 1650. Executed. She'd been sentenced to death for infanticide. Pretty common charge back then. She was hanged in the customary way, turned off a ladder, left to hang by the neck.
Okay.
And the remarkable part is that she hung for a full half hour, during which time her friends, trying to hasten her end, relieve her suffering, even pulled with all their weight upon her legs, sometimes lifting her up and then pulling her down again with a sudden jerk.
Oh my gosh. Half an hour with people pulling on her?
Yes. The crowd dispersed, everyone believing her dead.
And yet, despite that incredibly brutal procedure, she survived. That's almost unbelievable. What happened when they brought her body down?
Well, when her body was taken down, placed in a coffin, and transported to the private house of a Dr. William Petty for a scheduled autopsy, she was meant to be dissected.
Right.
She was observed to take a breath, and a distinct rattle was heard in her throat. Dr. Petty and his colleague, Dr. Thomas Willis, they immediately abandoned any thoughts of dissection.
I bet they did.
Yeah. They proceeded to try and revive her. They held her up in the coffin, wrenched her teeth apart, poured hot cordial into her mouth, which made her cough. They rubbed and chafed her fingers, hands, arms, feet, trying to restore circulation.
Wow.
After about 15 minutes of this really intense effort, they gave her more cordial. They tickled her throat with a feather, and she momentarily opened her eyes. They also administered a stomach plaster and enema to give heat and warmth to her bowels.
So it was a true multimodal approach, even without our modern understanding of physiology. What was the final outcome of these desperate, almost intuitive efforts?
Within 12 hours, Anne Green began to speak. 24 hours after her revival, she was answering questions freely, and within 2 days, her memory returned to normal. Except notably, she couldn't recall the execution itself or the resuscitation efforts.
Understandable.
Completely. She was later pardoned. Her survival was seen as, divine intervention. She went on to marry and have 3 children. What's truly fascinating here is how, even without any scientific understanding of physiology, they intuitively tried to restore warmth, circulation, vital functions. What we now recognize as a profound state of shock. It underscores this fundamental, almost instinctive drive to save life.
So, from these incredibly early, almost intuitive efforts, how did the medical concept of shock, as a distinct medical term, actually evolve?
Well, the term shock seems to have first appeared in 1743 in a translation of a French treatise by Henri-François Ledron. He used it to describe the physical impact or collision of battlefield wounds. More about the external trauma, not the internal physiologic response.
Ah, the physical blow.
Exactly. But by 1815, a British surgeon named Guthrie, in his book on gunshot wounds, used it to describe physiologic instability, which is much, much closer to our modern understanding of a systemic response to injury.
And the definition itself has continued to change and deepen over time, right? It's not just a single static concept.
Yes, profoundly so. The current widely accepted definition is inadequate perfusion of tissue. But that statement, it's far more nuanced than it appears.
Yeah.
Well, while oxygen is undoubtedly critical for cells, focusing on oxygenation alone is probably too simplistic. It's kind of elemental thinking. Blood is profoundly complex. It carries countless nutrients, buffers, cells, antibodies, hormones, antitoxins, all vital for cellular function and maintaining homeostasis.
Right.
So while oxygen delivery is critical, the modern definition of shock emphasizes overall tissue perfusion and the adequate delivery of this whole complex array of components, not just oxygen.
What about early theories on its specific cause? How did medical thinkers try to explain this rude unhinging of the machinery of life, as Gross put it?
For centuries, humoral theories, imbalances in bodily fluids like blood, phlegm, bile persisted until the late 19th century. Then, in 1872, the American surgeon Samuel D. Gross famously defined shock as a manifestation of the rude unhinging of the machinery of life, a very vivid description.
It is.
Later, in 1899, George Washington Crisel, using the new sphygmometers, blood pressure cuffs.
Right. The tech was advancing.
Exactly. He proposed that a profound decline in blood pressure accounted for all the symptoms of shock.
So he shifted the focus from just observing pulse and mental status to a measurable vital sign like blood pressure. That must have been revolutionary for diagnosis.
Precisely. Before Cradle, surgeons relied mainly on subjective observations, respiration rate, pulse quality, declining mental status. After his publications, blood pressure measurement became increasingly accepted as a key diagnostic indicator for shock.
Okay.
And crucially, Cradle also concluded that shock wasn't a process of dying, but rather a marshaling of the body's defenses in patients struggling to live. They were actively fighting to survive. He later deduced that the reduced volume of circulating blood rather than just diminished blood pressure was the most critical factor in shock. And this raised an important question. How did this evolving understanding of volume loss then influence our approach to resuscitation fluids?
We take intravenous or IV fluids totally for granted now. They're everywhere in medicine. But how did they actually enter medical practice? Was it a rigorous scientific process or something else?
Surprisingly, no. Not the rigorously scientific evidence-based process you might assume for something so fundamental. In 1830, a physician named Herman made one of the first documented attempts, trying to rehydrate cholera patients by injecting 6 ounces of water directly into a vein.
Just water.
Wow.
Just water.
Then, even more famously, in 1831, a physician named William O'Shaughnessy also treated cholera patients by administering large volumes of salt solutions intravenously. He published his rather startling results in Lancet.
Okay.
These were effectively the first documented attempts to replace extracellular and intravascular volume in a clinical setting, driven by the urgency, the high mortality of a cholera epidemic. But it's important to note, treating cholera and dehydration is a very different physiological problem from treating hemorrhagic shock. That distinction would become clearer much later.
So is that how normal saline, or what we sometimes call physiologic saline, came about? Did these early attempts solidify its use?
Not quite, and this is where the history gets really interesting and reveals some persistent misconceptions. A few decades later, 1882, a German physiologist, Hartog Jakob Hamburger, he was doing in vitro studies of red cell lysis, basically, looking at what made red blood cells burst.
Okay.
He incorrectly suggested that 0.9% saline matched the salt concentration in human blood. He bases on freezing point studies, which measure osmolality.
Ah.
So while it's still often called physiologic or normal saline today, it's actually neither truly physiologic for the human body nor normal when you give it in the large volumes often seen in resuscitation.
Yeah.
The historical misnomer that has just stuck.
Fascinating. Okay, what about Ringer's solution? That's also incredibly common today, maybe even more so than normal saline for certain things.
That's a truly wonderful story of scientific serendipity, or perhaps a fortunate laboratory shortcut. Sidney Ringer, a British physiologist in 1883, was meticulously studying isolated frog heart contractions.
Frog heart.
Frog hearts. He was using a simple saline solution for his experiments, but he noticed something curious. Adding a small quantity of white of egg to his saline solution significantly improved the heart's contractions.
Huh.
He initially concluded this beneficial effect was due to either albumin or potassium chloride in the egg white. He performed endless, painstaking experiments, altering multiple variables, trying to figure out what worked.
So what was the shortcut or the unexpected discovery that changed everything for Ringer?
Well, Ringer later published another article saying his previously reported findings, the egg white benefits, couldn't be consistently repeated. Through careful, almost obsessive study, he eventually realized the water used in his initial successful experiments was not distilled water, as he'd instructed and reported, but rather common tap water from the New River Water Company.
No way! The technician cut corners.
It seems so. The technician, paid to distill the water, had apparently just used tap water instead. Ringer, being a diligent scientist, then analyzed the tap water, found it contained various trace minerals, calcium, magnesium, sodium, potassium, along with some acids.
Wow.
Through more diligent experimentation, he discovered that potassium, calcium, and bicarbonate were the essential ingredients needed for robust, consistent heart contractions. And just like that, Ringer's solution, containing these elements in a balanced mix, became ubiquitous in physiological labs worldwide.
And this foundational solution then led directly to Hartmann's solution, or what we commonly call lactated Ringers today.
Yes, precisely. In 1932, an American pediatrician, Alexis Hartmann, modified Ringer's solution by adding sodium lactate. He wanted a more effective alkalinizing solution for his acidotic patients, especially kids with severe dehydration and acidosis. He chose lactate because its conversion into bicarbonate in the body, happens in the liver, is sufficiently slow. It avoids that danger of a rapid, dangerous shift from compensated acidosis to uncompensated alkalosis, which was a known risk with giving straight sodium bicarbonate.
Ah, a buffer for the buffer, almost.
In a way, yeah. The result was what we now commonly call lactated Ringers or Hartmann's solution, a cornerstone of fluid therapy.
So these foundational fluids, normal saline and lactated Ringers, were largely developed for dehydration, specific lab experiments, often based on early or even erroneous assumptions. Yet they gain widespread use even for things like hemorrhagic shock, right?
Indeed. And Rudolf Mattes, as early as 1924, he introduced the continuous IV drip for shock patients, but remarkably, he already warned of saline's potential dangers.
Really? Back then?
Back then, he stated, quote, "Normal saline has continued to gain popularity, but the problems with metabolic derangements have been repeatedly shown, but seem to have fallen on deaf ears." Fast forward to modern studies, and we see normal saline can actually cause significant issues. Abdominal discomfort, nausea, drowsiness, decreased mental capacity, even in healthy volunteers. It's truly remarkable how, despite immense scientific advances elsewhere in medicine, our basic resuscitation fluids haven't progressed commensurately. After a few hours, only about maybe 175 to 200 milliliters of a 1 liter infusion of normal saline actually stays in the blood vessels. The rest just leaks out.
Leaks out where?
Into that interstitial space, that third space we talked about, which highlights its poor retention and the huge amount that ends up essentially outside the circulation. 2, the physiology of shock, from vital signs to cellular metabolism.
All right, let's move into how clinicians actually assess shock in a real-world scenario. When a patient arrives in shock, how do they typically evaluate them? What's the traditional approach? Maybe what's taught in an ATLS course?
Or the Advanced Trauma Life Support, or ATLS course, which is designed more for non-surgeons like ER docs and paramedics. It classically defines 4 classes of hemorrhagic shock. These classes are based on the estimated percentage of blood loss and the corresponding changes in vital signs: heart rate, blood pressure, respiratory rate, urine output. For instance, according to ATLS, class 3 shock involves, say, a 30-40% estimated blood loss. And that's supposedly when you see a significant drop in blood pressure.
But you mentioned earlier that these classifications, while widely taught, are problematic in practice. Why is that the case for clinicians actually at the bedside?
Well, they weren't rigorously tested or proven in diverse patient populations. In reality, the manifestations of shock are often highly confusing, especially in complex trauma patients.
How so? Give me an example.
Okay, so changes in mental status could be due to severe blood loss and brain hypoperfusion, right?
Right.
But it could also be caused by a traumatic brain injury itself, or severe pain, or even the effects of illicit drugs or alcohol.
Ah, confounders.
Exactly. Same dilemma applies to changes in respiratory rate or skin color. Might signal hypoperfusion, sure, but could also be due to a pneumothorax, pain from rib fractures, and inhalation injury. This variability makes a rigid, class-based diagnosis really challenging and often unreliable at the bedside.
So, given these complexities, what's considered the most useful clinical measure when assessing shock in an acute setting, if the classes aren't perfect?
Blood pressure remains the most useful clinical measure, especially the systolic pressure. But, and this is a big but, it's crucial to remember that a patient's baseline blood pressure and their absolute blood volume are extremely variable and often unknown when treatment begins.
Right, you don't have their history right there usually.
Exactly. Moreover, there isn't a single universal endpoint for resuscitation that applies to every single patient. Instead, astute clinicians rely on a combination of factors.
Like what?
Things like the normalization of serum lactate, a positive trend in base deficit, restoring normal pH where applicable, obviously, definitive hemorrhage control, and maybe most importantly, the patient's overall clinical status and their mental responsiveness. It's a whole picture.
What about heart rate? That's so often seen as a primary, immediate indicator of bleeding or shock. Everyone thinks a rapid pulse means significant blood loss.
Yeah, that's the common wisdom. While a heart rate over 100 beats per minute has traditionally been used as a sign of bleeding, especially in ATLS, the evidence for its true significance as a standalone marker is surprisingly minimal.
Really?
Yeah. Studies have shown that heart rate is neither sensitive nor specific for determining the need for emergent intervention, or the need for blood transfusions in the first couple of hours, or even accurately gauging the severity of the injury itself.
Why not?
Well, think about it. Pain, or just nervousness, anxiety, those can also significantly elevate heart rate. It can mask the true underlying cause or lead you to overestimate blood loss.
And what about this paradox of relative bradycardia in bleeding patients? That sounds incredibly counterintuitive, a slow heart rate when someone is losing blood.
This phenomenon, it truly raises an important question and highlights the complex, sometimes paradoxical nature of the body's response to severe stress. For instance, in severe arterial hemorrhage in some animal models, the animals don't show tachycardia, a fast heart rate. Instead, they can become bradycardic, slow.
Why would that happen?
It's speculated this is a teleological mechanism, kind of an evolutionary adaptation, to reduce cardiac output and minimize uncontrolled bleeding. Basically conserve what little blood volume remains.
Wow.
Interestingly, this relative bradycardia, which is defined as a heart rate less than 100, while simultaneously having a systolic BP below 90. It also occurs in humans.
And the outcome?
When bleeding patients exhibit this relative bradycardia, their mortality rate is actually lower, provided the heart rate isn't profoundly low like below 60 is usually a morbid state. In fact, bleeding patients with a heart rate between 60 and 90 actually have the highest survival rate compared with patients experiencing tachycardia, meaning over 90. It totally challenges our deeply ingrained assumptions.
So our conventional wisdom about heart rate might be significantly oversimplified. What about hemoglobin levels? You'd think that would be a straightforward, immediate indicator of blood loss.
Yeah, you'd think. Traditionally, hemoglobin and hematocrit levels were thought unreliable in predicting acute blood loss, especially in patients who haven't been resuscitated yet, because the blood hasn't had time to, dilute.
Right.
However, in patients who have received crystalloids, those artificial fluids we discussed, a rapid drop in hemoglobin can occur within minutes. As the infused fluid equilibrates throughout the vascular space, it dilutes the remaining red blood cells.
Ah, okay.
So while a high or normal hemoglobin level doesn't rule out significant bleeding, a low level, because it occurs quite rapidly in a resuscitated patient, generally does reflect severe blood loss and warrants immediate aggressive attention.
If individual vital signs like heart rate and blood pressure aren't always accurate on their own, What about combining them into a single, maybe more powerful metric?
That's exactly why the shock index, or SI, was developed. It's simple. Heart rate divided by systolic blood pressure.
Okay.
It's been shown to be a better marker for assessing shock severity than heart rate and BP alone. It gives a more integrated picture. Its utility extends beyond just trauma patients in hemorrhagic shock to those in shock from other causes like sepsis, obstetrics, heart attacks, other acute illnesses. It's even proven beneficial in kids and older adults. And it correlates with the need for interventions, like blood transfusions.
And what's the modified shock index, or MSI? How does that differ?
The MSI refines this a bit. It uses heart rate divided by the mean arterial pressure, the MAP, which accounts for both systolic and diastolic BP.
Okay, incorporates more info.
Right. A rising MSI indicates hypodynamic circulation, low stroke volume, low systemic vascular resistance. It's generally considered a better predictor of mortality than the standard SI because it incorporates more pressure information.
So these seem like really valuable tools for clinicians trying to make rapid decisions. Why aren't they more widely adopted and uniformly applied in everyday practice?
Well, statistically, these indices are better than single parameters. They don't replace the experienced clinician at the bedside.
Ah, the art of medicine.
Exactly. An astute surgeon, drawing on years of experience, quickly considers multiple variables. Patient's gender, age, Glasgow Coma Scale score for neurostatus, the specific mechanism of injury, other subtle physiologic parameters, all in a matter of seconds. This complex, rapid mental calculation by a seasoned professional, it still surpasses simple indices like SI or MSI in terms of real-time clinical decision-making. While the indices are statistically more accurate than one individual parameter, there's just no substitute for that seasoned, holistic clinical judgment.
Let's turn to lactate. That's a lab value that has always been a key marker for injury and ischemia in the body. But our understanding of it seems to be changing quite profoundly, almost flipping our traditional view, right?
This truly raises an important question and challenges deeply held beliefs. For a long, long time, we thought we knew lactate. But new data are profoundly confusing, suggesting we may not understand its true implications at all.
Okay.
Lactate was routinely seen as merely a byproduct of anaerobic metabolism, a sign that cells weren't getting enough oxygen and were shifting to this inefficient, dirty energy production. It was seen as an unfavorable waste product.
Like the firefighters example in the source.
Yeah.
Associated with fire, so they must be bad.
Exactly. Perfect analogy.
Right.
But physiologists are now questioning that old paradigm quite aggressively. Lactate appears to behave far more advantageously than we previously thought.
How so?
It's being studied as a pseudohormone, meaning it acts like a hormone, regulating cellular redox states, promoting wound regeneration through increased collagen deposition, neovascularization,
Wow.
inducing vasodilation to improve blood flow, stimulating fat and carbohydrate oxidation for energy. Even tissues with ample oxygen supply produce lactate when they're distressed.
So it's not just a sign of trouble, but potentially part of the body's solution, or a vital signaling molecule that helps rather than harms.
Yes, that's the emerging picture. Studies now show lactate may even be the preferred fuel for the brain and heart, used even before glucose. And it appears protective to brain tissues in traumatic brain injury. So while its level certainly signifies tissue distress, whether from anaerobic conditions or other factors, it's a far more active and potentially beneficial molecule than previously thought. Plus, the release of epinephrine and other stress hormones also causes a physiological rise in lactate, which further complicates just looking at the number.
What about base deficit, another common lab value measured in shock that seems to go hand in hand with lactate?
Right, base deficit. It's a measure of the amount of base needed to correct the pH of a liter of blood back to 7.4. It seems to correlate pretty well with lactate levels, at least in the first 24 hours after a significant insult like trauma or hemorrhage.
Okay.
An elevated base deficit is generally seen by most clinicians as an indication of ongoing shock, and it's often associated with a higher mortality rate in injured patients. It reflects the overall metabolic acidosis.
Are there any important caveats or considerations with base deficit measurements that clinicians need to be aware of, things that might throw it off?
Yes, definitely. It's commonly influenced by the chloride content in resuscitation fluids. That can lead to what's called a hyperchloremic non-gap acidosis. Meaning, if you infuse large amounts of normal saline, which has a higher chloride concentration than plasma, it can artificially lower the bicarbonate and increase the base deficit, even if the patient isn't truly in profound shock from underperfusion.
Ah, okay, so the fluid itself messes with the number.
Exactly. Also, in patients with renal failure, base deficit can be a poor predictor of outcome because their kidneys aren't clearing acids effectively anyway. And if hypertonic saline is used therapeutically, the hyperchloremic acidosis it causes is generally considered harmless, but you still need to interpret the base deficit cautiously, understanding the influence of the administered fluids.
When the body goes into shock, it has this incredible array of built-in defenses, compensatory mechanisms that kick in almost immediately. What are some of the key players in this complex hormonal symphony?
It's quite a marvel of biological engineering, really, a true cascade of survival responses. When blood flow and pressure decrease, the juxtaglomerular apparatus in the kidney responds by producing the enzyme renin.
Okay.
This kicks off the renin-angiotensin-aldosterone system, eventually leading to the generation of angiotensin II. This is a potent hormone. It stimulates an increased sympathetic drive at the nerve terminal level, prompting the adrenal medulla, the inner part of the adrenal gland, to release a surge of catecholamines.
Epinephrine, norepinephrine.
Epinephrine, norepinephrine, dopamine. These hormones are responsible for the elevated glucose level often seen in hemorrhagic shock, though its precise role isn't fully understood. They primarily cause vasoconstriction tightening blood vessels to shunt blood to vital organs, and they increase heart rate.
And the adrenal cortex, the outer part of the adrenal gland, is also involved with cortisol and aldosterone, right?
Yes, absolutely. Cortisol, released from the adrenal cortex, plays a major role in fluid equilibrium, stress response, modulating inflammation. And the zona glomerulosa of the adrenal cortex produces aldosterone in response to that angiotensin II stimulation.
And aldosterone does what again?
Aldosterone is a crucial mineralocorticoid. It modulates renal function by increasing the recovery of sodium and the excretion of potassium in the kidneys. Since sodium is the primary osmotic ion regulating water balance, its reabsorption directly leads to intravascular volume expansion, a critical compensatory response to shock.
So what does this all mean for a surgeon trying to manage a patient in shock during resuscitation? It sounds like an internal battle the body is fighting.
It means the body has this complex, multi-layered interplay of hormones and physiological systems designed to maintain volume and blood pressure for as long as possible. This intricate dance of compensation is aimed at keeping vital organs perfused.
But it can't last forever.
Exactly. It's crucial for the surgeon to understand that the release of these hormones is not infinite. Their supply can be exhausted in a state of ongoing, prolonged shock. This highlights the absolute urgency of addressing the underlying cause of shock, whether it's massive bleeding or a severe infection, rather than solely relying on these internal compensatory mechanisms that will eventually fail.
Let's turn to the lethal triad, a critical concept for understanding severe shock and its devastating progression. What exactly are its components, and how do they interact to create such a vicious cycle that can rapidly lead to death?
Right, the lethal triad. It consists of acidosis, hypothermia, and coagulopathy. These three are incredibly common in severely bleeding or shocked patients, especially those who've undergone aggressive resuscitation.
Okay, so how do they connect?
The basic understanding is this. Inadequate tissue perfusion, the hallmark of shock, leads to widespread cellular dysfunction and the accumulation of acidic byproducts, mainly lactate. That causes acidosis.
Yeah.
This inadequate delivery of nutrients and oxygen also impairs the body's ability to produce its main energy molecule, ATP. This makes it incredibly difficult to maintain core body temperature, which then leads to hypothermia.
And then how do these three elements work together in such a destructive, reinforcing way? What makes it a triad?
The resulting hypothermia and acidosis profoundly affect the efficiency of enzymes throughout the body, particularly those critical for the coagulation cascade, the complex series of steps that leads to blood clotting.
Enzymes need the right temperature and pH.
Exactly. They work optimally within a narrow range. If they aren't functioning properly because it's too cold or too acidic, coagulopathy clotting problems worsens dramatically. This in turn contributes to uncontrolled bleeding, which then further fuels the entire triad by perpetuating inadequate perfusion, worsening acidosis, and driving down body temperature even further. It's a vicious, self-perpetuating cycle of death. Each component exacerbates the others, making it incredibly difficult to escape without aggressive intervention.
So the key to breaking this vicious cycle is stopping the bleeding and aggressively addressing the hypothermia. What's the primary concern for surgeons regarding hypothermia in this context?
Exactly. Stop the bleeding, warm the patient. And it's important to note that hypothermia in trauma often isn't spontaneous from the injury itself or ischemia. It's frequently induced or worsened by infusing large volumes of room temperature IV fluids or cold blood products during resuscitation. We inadvertently make it worse.
Right.
While accidental hypothermia survivors have been recorded at extremely low temperatures, like 13.7 degrees C, which is 56.7 degrees Celsius, for an extreme skier who fully recovered.
Unbelievable.
Trauma patients traditionally had a 100% mortality rate if their core temp reached 32 degrees C. While a small number have recently survived below that, hypothermia in trauma is generally due to shock itself, and it actively perpetuates uncontrolled bleeding because it causes coagulopathy. Trauma patients with a postoperative core temp below 35 degrees C have a fourfold increase in death. It's a major predictor.
How does cold specifically affect coagulation, the body's ability to clot blood?
Cold directly decreases the activity of crucial enzyme systems involved in clotting. It enhances fibrinolytic activity, the breakdown of clots, which you don't want when bleeding, and it causes platelet dysfunction. The platelets just don't work right when they're cold. Even a drop in core temp of just a few degrees Celsius can result in a 40% inefficiency in some critical clotting enzymes.
40%. Wow.
Yeah. And this raises an important question for clinicians. Coagulation tests in the lab. They're universally done at 37 degrees C normal body temp.
Ah, so the lab result isn't reality for a cold patient.
Exactly. A cold patient is always more coagulopathic than their lab results indicate. A seemingly normal coagulation profile in a cold patient does not accurately represent what's actually going on in their body. It can lead to a false sense of security.
So given that, warming fluids before they go in to prevent further cooling is vital, rather than just relying on them to actively warm the patient, right?
Exactly. That's a critical distinction in clinical practice. A single liter of refrigerated blood stored at 4 degrees C can cool a patient by half a degree Celsius. It takes about 2 liters of cold blood or 5 liters of room temp crystalloid to cool a patient by 1 degree C.
So the warmers are defensive.
Primarily defensive, yes. The main reason for fluid warmers isn't necessarily to actively warm patients who are already cold, but to prevent them from getting colder during ongoing resuscitation. That prevents worsening outcomes and perpetuating the lethal triad. Preventing further heat loss is absolutely key.
You mentioned acidosis is a key part of this lethal triad. Is it always a detrimental factor, or is there a more nuanced understanding emerging about its role, maybe even some benefits?
That's a great question, and the answer is surprisingly nuanced. While decreased perfusion certainly causes lactic acidosis and contributes to consumptive coagulopathy, and cold fluids worsen hypothermia and dilutional coagulopathy, some researchers believe the acidotic state itself isn't entirely undesirable in the very acute phase of shock.
Really? Why?
Well, oxygen is more easily offloaded from hemoglobin in an acidotic environment. That's the Bohr effect, which could be seen as beneficial for tissue oxygenation, right? Getting oxygen where it needs to go.
Okay, makes sense.
Furthermore, basic scientists find that cells tend to live longer in acidic conditions when preserved ex vivo, outside the body, suggesting maybe a protective mechanism at the cellular level.
So correcting it directly with bicarbonate just to chase a lab value isn't always the goal and could even be harmful.
Classically, yes. Treating acidosis by just correcting a lab number on paper has been cautiously avoided. The clinical consensus has long been that the focus should always be on treating the underlying cause of the shock. For a surgeon, that's typically definitive control of bleeding or revascularizing ischemic tissue.
Right. Fix the problem, not the number.
Exactly. Rapidly injecting sodium bicarbonate can even worsen intracellular acidosis because the CO2 generated diffuses rapidly into cells.
Yeah.
However, there's an interesting practical nuance.
Whoa.
Bicarbonate infusion often causes a rapid rise in blood pressure in hypotensive patients. This isn't just about pH correction. A 50 milliliter ampule of sodium bicarbonate is essentially a hypertonic sodium bolus. Physiologically, it's similar to giving small doses of hypertonic saline, rapidly drawing fluid into the vascular space, which can temporarily boost BP.
Ah, an osmotic effect, too. What about alternative buffers to sodium bicarbonate for addressing acidosis? Is anything else being explored or used?
THAM, or tromethamine, is a fascinating alternative. It's a biologically inert amino alcohol. It buffers both CO2 and acids. Crucially, it's sodium-free, and it limits CO2 generation during buffering, which is important.
Why is limiting CO2 important?
Because unlike bicarbonate, which needs an open system like the lungs to eliminate CO2 for its buffering effect, THAM works in closed or semi-closed systems, and it maintains its buffering ability even during hypothermia.
Okay. Where is it used?
It's used in conditions like acute respiratory distress syndrome, ARDS, diabetic acidosis, certain drug intoxications, and even to manage increased intracranial pressure after brain trauma. But while it has these theoretical advantages, its clinical efficacy over sodium bicarbonate hasn't been consistently documented in large definitive trials. So it's not standard practice everywhere.
The third leg of the lethal triad is coagulopathy problems with blood clotting. What makes it so challenging to manage in surgical patients, especially those in severe shock, massive bleeding?
Coagulopathy in these patients is incredibly multifactorial. We've talked about the acidosis and hypothermia, right? The other major cause is a dramatic decrease in the body's clotting factors. This happens either because they're rapidly consumed during active uncontrolled bleeding or because they get diluted out by the massive infusion of artificial fluids like saline or LR, which are devoid of these crucial clotting factors.
Okay.
The big problem is that traditional lab tests like prothrombin time, PT, partial thromboplastin time, PTT, and international normalized ratio, INR,
Yeah.
they're often inaccurate and insufficient for detecting coagulopathy in these rapidly deteriorating surgical patients.
Why are those traditional tests insufficient in such a rapidly evolving clinical scenario?
Well, one major reason is that coagulopathy is a dynamic state. It constantly evolves through stages. Hypercoagulability, not clotting enough, sometimes hypercoagulability, clotting too much, and fibrinolysis, breaking down clots. Traditional tests only give you a snapshot in time. They can't detect this rapid evolution.
Right.
Furthermore, these tests are done at normal pH and temperature in the lab, so they don't account for the real world. Profound effects of hypothermia and acidosis on coagulation in a bleeding patient. Got it. They're also performed on plasma, not whole blood, so they don't accurately measure the functional interaction of coagulation factors, platelets, and other cellular components in forming a stable clot. It's just not the full picture.
So what are the better, more advanced tools for assessing clotting in real time, maybe at the bedside?
Thrombolithography, or TEG, and rotational thromboelistometry, often called ROTEM, are emerging as dynamic and more sensitive measures. They give a more comprehensive and accurate assessment of coagulation changes because they're performed on whole blood.
Whole.
Yes. And they directly measure clot strength, which is the final product of the coagulation cascade. They account for the interactions between clotting factors and platelets in a way traditional tests just can't.
What kind of information do they give?
TEG parameters like R time, how long it takes for the clot to start forming, the alpha angle, how fast the clot builds, and maximum amplitude, ANA, the ultimate clot strength, provide real-time information. You can even assess fibrinolysis, the breakdown of clots. And that can guide therapies like giving tranexamic acid.
What exactly is tranexamic acid, or TXA, and how does it fit into this strategy for managing coagulopathy?
TXA is an antifibrinolytic medication. It's a synthetic analog of the amino acid lysine. Essentially, it works by stopping plasminogen from becoming plasmin, thereby preventing the breakdown of existing blood clots and helping to stabilize them.
So it helps keep the clots you have.
Exactly. It's inexpensive, widely available, relatively easy to use. The CRSH2 trial, a massive multi-center randomized study, over 20,000 patients, showed TXA significantly reduced all-cause mortality in bleeding trauma patients. Especially is given within 3 hours of injury.
Wow.
This powerful evidence rapidly influenced both military and civilian treatment guidelines worldwide, changed clinical practice. However, it's worth noting, some critics point to the small absolute risk reduction, about 1.5%, given the study's enormous size, questioning its broader clinical relevance. But its low cost and ease of use remain very attractive.
So we've broken down the lethal triad, understanding how it creates this vicious cycle of death. But beyond these immediate physiological dangers, for decades, much of critical care focused on a broader concept, oxygen delivery. How did this aggressive focus on supernormalizing oxygen delivery emerge, and what critical lessons did it teach us about the body's response to shock?
Yeah, you've hit on a fascinating and somewhat controversial chapter in critical care history. Much of what we know about oxygen delivery and consumption started with the brilliant physiologist Archibald V. Hill. He famously unraveled the distinction between aerobic and anaerobic metabolism and won a Nobel Prize for it in 1922.
Okay.
He defined terms like maximum O2 intake and O2 debt, laying the theoretical groundwork. Oxygen delivery, or DO2, it's a relatively simple calculation. Cardiac output multiplied by the oxygen content in arterial blood.
And this led directly to the concept of optimization or supernormalization of oxygen delivery. That sounds incredibly aggressive. What was the thinking behind that approach?
It was indeed very aggressive. In the late 1980s, William Shoemaker, a real pioneer in surgical critical care, theorized that shock created a profound oxygen debt that absolutely needed to be repaid.
Like a bank loan.
Kind of, yeah. His idea was to aggressively maximize oxygen delivery,
Yeah.
often pushing cardiac outputs to an astonishing 15 liters per minute or more for days until oxygen consumption no longer increased.
15 liters a minute, that's huge.
Huge. The assumption was this would repay the cellular oxygen debt, reverse organ dysfunction, and ultimately improve patient outcomes by preventing things like multiple organ dysfunction syndrome, or MODS. This involved rapid, continuous boluses of fluids and inotropic drugs like dobutamine to boost cardiac output.
That sounds like a monumental effort. Did this very aggressive strategy actually work in practice? Did it improve patient survival?
Well, while Shoemaker's early, non-randomized trials showed promise suggesting reduced MODS and lower mortality, subsequent larger randomized controlled studies unfortunately failed to replicate his success.
Oh.
In fact, the aggressive use of fluids to achieve these supernormal oxygen delivery goals actually caused increased multiple organ failure, abdominal compartment syndrome, and paradoxically higher mortality, likely due to the excessive crystalloid infusions and the associated inflammatory response they triggered.
So the very intervention meant to help ended up harming patients, leading to complications it was designed to prevent. That's a profound lesson.
Precisely. And this led directly to the decline of the pulmonary artery catheter, the Swan-Ganz, which was central to this oxygen optimization strategy. Its routine use has virtually disappeared from the modern surgical ICU, except in very specific, highly monitored cardiac surgery cases.
Why did it fall out of favor?
Critics argued the body was often already at the flat part of the oxygen consumption curve, meaning more oxygen delivery wasn't leading to more actual oxygen consumption by the cells, it was just flooding patients with fluids. And this excess fluid, often crystalloids, could cause a systemic inflammatory response, contributing to MODS. This entire saga, it really raises an important question. How do we truly define optimal resuscitation endpoints without causing iatrogenic harm caused by treatment?
Beyond global measurements like blood pressure, how do we know if individual organs or specific regions of the body are getting enough blood flow? Where does the blood actually go during shock when the body is prioritizing?
Right. During hemorrhage or hypovolemia, the body exhibits this remarkable, crucial compensatory mechanism. Blood flow is actively redirected to vital organs. Brain, heart, liver, kidneys get priority.
Okay.
This is often done at the expense of less essential tissue, bed, skin, skeletal muscle, and importantly, the gut. This physiological shunting, while life-saving in the short term, can lead to prolonged ischemia in the gut. And that, in turn, can contribute to a systemic inflammatory response later on. This phenomenon led to extensive research into monitoring regional perfusion, trying to track the consequences of this redirection.
What specific methods were explored to monitor this regional flow in real time?
Gastric tonometry, for instance, was heavily researched for a period. This method aimed to measure the adequacy of blood flow in the GI tract by assessing CO2 levels in the stomach, an indirect marker of perfusion.
Did it work?
Well, while it could, in some studies, predict patient survival, ironically, resuscitating patients to an improved tonometry value showed no survival benefit in subsequent trials.
Huh.
Consequently, the method has largely been abandoned by most clinicians. Logistic difficulties, cost, and lack of demonstrable impact on patient outcome kind of doomed it.
So what's considered the next more promising frontier in regional monitoring, something that might actually help guide treatment?
Near-infrared, or NIR, spectroscopy looks very promising.
Ah.
It's non-invasive, simple, relatively cheap, portable. Light in the NIR spectrum has this unique ability to penetrate skin and bone, allowing for direct, continuous assessment of tissue metabolic rate and oxygenation, particularly in areas like the hand.
Like a pulse oximeter.
Exactly. The pulse oximeter is a common, everyday medical device using NIR technology that's become standard in medicine for measuring oxygen saturation in arterial blood.
And how is NIR spectroscopy specifically being applied to assess shock and potentially guide resuscitation?
A large, multi-center study in trauma patients found that an NIR probe placed on the thenar muscle, that fleshy part at the base of the thumb,
Okay.
was as sensitive as base deficit in predicting death and MODS in hypotensive trauma patients. Its negative predictive value was an impressive 90%, meaning it could reliably rule out occult hypoperfusion hidden circulatory problems in these patients.
Sounds great. So what's the holdup?
Well, the ongoing debate now is whether this technology will genuinely change treatment decisions and improve outcomes, or like the supernormalization era with the pulmonary artery catheter, will it lead to over-resuscitation by trying to fix an abnormal number that may or may not be clinically relevant in the broader picture?
Right, finding that sweet spot.
Exactly. The true optimal endpoint of resuscitation remains a constant and evolving debate.
Finally, in this section, let's touch on septic shock. This is a different form of shock caused by severe infection, but it also has its own complex fluid challenges. What has been the major shift in its management over the last couple of decades?
Right. Sepsis. In 2001, a highly influential study, the RIVERS trial, reported significantly lower mortality with early goal-directed therapy, or EGDT, for severe sepsis and septic shock patients treated in a single emergency department.
Okay, EGDT.
This influential study led to the widely adopted Surviving Sepsis Campaign guidelines. These prescribed central venous catheterization to guide aggressive fluid and vasopressor use, along with other interventions, to achieve specific physiologic targets, like central venous pressure and mixed venous oxygen saturation. Very protocolized.
But I understand the landscape and understanding around this has changed recently, perhaps in a surprising way.
Yes, more recent large-scale randomized studies, Process, Arise, Promise, have since shown that this kind of protocol-based care for early septic shocks does not improve outcome compared to usual care when implemented across multiple centers.
So the fancy protocol wasn't better than just good clinical care.
It suggests that usual care itself may have already adopted many of the beneficial principles of EGDT, diminishing the perceived difference. What's also fascinating here is how the very definition of sepsis has changed. We've moved away from the old systemic inflammatory response syndrome, or SIRS, criteria towards the more specific sequential organ failure assessment, or SOFA, score.
Okay.
And there's also a simpler bedside version, QS-SOFA, which looks for quick indicators. Cachipnea, fast breathing, altered mental status, and hypotension as triggers for concern. This reflects a shift towards identifying organ dysfunction more directly rather than just inflammation. 3. The evolution of resuscitation. Lessons learned in modern protocols.
We've seen how fluid therapy has evolved over centuries, but there's this growing and frankly kind of surprising understanding that the fluids themselves, those seemingly benign crystalloids like saline and LR, can actually be detrimental. How did this crucial realization that fluids could go from healing to harming first come about?
Well, the initial lessons came, ironically, from wartime again. The Korean War highlighted the immense utility of blood products in saving lives. But by the Vietnam War, excessive volume resuscitation with crystalloids, often far beyond just replacing shed blood, became standard practice.
Why the shift to so much crystalloid?
It was heavily influenced by studies like Tom Shire's classic work in the 1960s. Using a dog model, he showed better survival rates with lactated drinkers resuscitation compared to just giving back the shed blood alone. This led the surgical community to aggressively embrace crystalloids, believing more fluid is always better to, fill the tank.
And this aggressive, crystalloid-heavy approach in Vietnam led to what was infamously called Da Nang lung, or ARDS, acute respiratory distress syndrome. How did that connect to fluid management?
Yes. Initially, the explanation for Da Nang lung was that, patients were simply living long enough to develop ARDS due to improved care and faster helicopter transport from the battlefield.
Made sense at the time, maybe.
It seems plausible. However, this explanation lacked supporting evidence when rigorously examined. Data showed that killed in action rates, those who died before reaching a surgeon, hadn't changed for over a century, suggesting initial trauma mortality wasn't dramatically altered.
Okay.
Moreover, died of wounds rates, those who died after reaching medical facilities, were even slightly higher in Vietnam, despite significantly faster transport times.
Higher? Wow.
Yeah, this directly challenged the idea that patients were just living longer. The true realization that the fluids themselves were problematic began to emerge in the late 1990s.
So what specifically did we learn about the fluids themselves that caused this profound paradigm shift, making us question their widespread, seemingly benign use?
A pivotal U.S. Navy study in 1996, using a swine model of hemorrhagic shock, showed something truly enlightening. Neutrophils, a type of white blood cell, key player in inflammation, were activated not just after hemorrhagic shock and resuscitation with LR, but also in control animals who only received LR solution without any hemorrhage.
So the fluid itself caused the inflammatory response, even in the absence of trauma or bleeding. That's a game changer.
Precisely. A total game changer. These astonishing findings were repeated in human blood and in various animal models. It became clear The inflammatory changes and subsequent organ damage depended directly on the type and amount of fluid used. Despite achieving similar physiological results, like restoring blood pressure, the immunological results were profoundly different. It was ultimately recognized that the type and massive quantity of artificial fluids were directly responsible for causing systemic inflammation, leading to severe complications like ARDS and obese.
Yeah.
They were not inert bystanders. They were actively causing harm.
This completely changed the paradigm around commonly used fluids like lactated ringers and normal saline, which had been considered basically harmless for so long.
Indeed. We realize blood is incredibly complex.
Yeah.
It contains countless crucial factors for clotting, immunity, oxygen transport, and these simple crystalloid solutions, developed over a century ago, are very poor replacements when used in massive quantities.
Right.
Further research even showed that replacing the D-lactate isomer in LR solution, it's a racemic mixture, meaning both forms of lactate are present, with other energy sources, like ketones, significantly attenuated the inflammatory response.
Interesting.
This led the Institute of Medicine in 1999 to recommend that LR be manufactured only with the L+ lactate isomer, which Baxter and other manufacturers have since done. They also suggested back then that 7.5% hypertonic saline was potentially the optimal resuscitation fluid due to its decreased inflammatory response and significant logistic advantages, like smaller volume.
This understanding of fluid harm led to a major revolutionary shift in military medicine with the adoption of damage control resuscitation, or DCR. What are its core principles, and how did it differ from the civilian approach at the time?
Right, DCR. The U.S. Navy's Committee on Tactical Combat Casualty Care, TCCC, formed in 2000, developed revolutionary guidelines for combat casualties, dramatically different from civilian recommendations at the time. Their core principles include, first, permissive hypotension, meaning accepting a lower blood pressure temporarily until definitive surgical control of bleeding is achieved, rather than aggressively normalizing it right away, which could pop clots.
Okay.
Second, minimizing crystalloid use. Use as little as possible. Third, initial use of small volumes of 5% hypertonic saline. And most crucially, early and aggressive use of blood products. Packed red blood cells, PRBCs, fresh frozen plasma, FFP, and platelets in balanced ratios.
So the focus shifted dramatically from aggressively pushing crystalloids to stopping the bleeding and replacing blood components as quickly and effectively as possible.
Exactly. A profound departure. Clinical studies in military settings, particularly the Iraq and Afghanistan wars, showed this DCR approach actually reduced the total volume of PRBCs needed by 25%, and dramatically decreased the incidence of ARDS in trauma patients from about 25% of ICU admissions down to just 9%.
That's huge. Why was this approach so effective? What's the mechanism?
Well, it's believed that trauma and shock cause what's now called endotheliopathy of trauma. The vascular lining, the endothelium, degrades and becomes permeable, leaky.
Ah, the pipes get leaky.
Exactly. Aggressive crystalloid resuscitation, especially with LR, exacerbates this leakiness. It leads to massive fluid shifts into the interstitial space, causing things like abdominal and limb compartment syndromes. DCR mitigates this by reducing that crystalloid load and providing what the body actually needs. Blood components that help restore the integrity of the vascular system, maybe even heal that leaky endothelium.
In a fascinating full circle moment, the military recognized the profound benefits of fresh whole blood for resuscitation. This seems like a return to very early resuscitation concepts, but with modern understanding, right?
It is indeed a powerful return, but yeah, with modern understanding and safeguards. During the Iraq War, military surgeons, initially hesitant due to historical concerns about disease transmission,
Right.
began activating walking blood banks. This involved pre-screened, typed non-combat soldiers donating fresh whole blood directly at the point of care, like in the field hospital.
Wow.
They found that patients resuscitated with whole blood just didn't seem to have the severe coagulation or pulmonary problems seen previously with crystalloid-heavy approaches. These patients were warmer, less acidotic, less coagulopathic, even after massive transfusions.
That's a huge shift from the crystalloid-heavy approach that was standard for so long. It truly underscores the complexity of blood itself.
Indeed. This prompted military surgeons to advocate for aggressive fresh frozen plasma use, even before whole blood was widely available again, as FFP was considered vastly superior to crystalloids for correcting coagulopathy. Now, liquid cold-stored whole blood is being used in select civilian trauma centers too. It offers another option with extended storage capabilities, up to 35 days, making it more practical.
It's a powerful testament to how practical battlefield experience can drive fundamental changes in medical practice.
Absolutely. Often forcing a reevaluation of long-held beliefs based on maybe incomplete lab data.
Since whole blood isn't always readily available in the civilian sector, efforts have focused on replicating its benefits using blood components. What is the 1.1.1 ratio, and why is it so important in current trauma resuscitation?
Right, the 1.1.1 ratio. It refers to transfusing plasma, platelets, and packed red blood cells in roughly equal proportions, often as a rapid empirical approach, meaning based on the clinical situation, not waiting for labs.
Okay.
Historically, component transfusion was guided by lab results like PT and PTT, but this practice was problematic. Lab tests significantly delayed the time to transfusion, and they often didn't accurately represent the dynamic, rapidly evolving clinical scenario of exsanguinating patients bleeding to death who are being aggressively resuscitated. Waiting for results meant critical, often fatal, delays.
So it's about giving these components early and empirically without waiting for lab results to try and get ahead of the bleeding and coagulopathy.
Yes, exactly. This empirical approach is key. Retrospective studies in combat casualties, and later confirmed in civilian settings, show that higher ratios of plasma and platelets to red blood cells were consistently associated with improved survival and reduced coagulopathy, especially when given early, within the first 6 hours of injury.
And there was a study confirming this.
Yes, the prospective observational pre-OM MTT study further confirmed that clinicians were naturally gravitating towards these higher ratios anyway, and it demonstrated improved 6-hour survival with early plasma transfusion. The underlying mechanism is thought to be the delivery of increased clotting factors in functional platelets, which helps address that endotheliopathy of trauma and reduce vascular permeability by stabilizing the blood vessels themselves. It's not just plugging holes, it's helping the pipes heal.
All this evolving evidence regarding fluid harm and the profound benefits of balanced blood components led directly to the development of massive transfusion protocols, or MTPs. What exactly are they, and how do they work in practice to save lives?
MTPs, massive transfusion protocols. They're essentially hospital-wide directives, pre-planned protocols specifically designed to streamline the empirical, rapid use of blood components for severely injured patients who are predicted to require massive transfusions, typically defined as needing more than 10 units of red blood cells in 24 hours, though the definition varies.
Okay.
Implementing an MTP has been shown to significantly improve survival in trauma patients, so much so that it's now a requirement for trauma center verification by organizations like the American College of Surgeons.
So it's about speed and pre-planned, organized access to blood products, ensuring they're delivered effectively and efficiently.
Precisely. An MTP typically dictates that for a severely injured patient meeting criteria, the blood bank immediately provides a pre-packaged cooler. It might contain, for example, 4 units of type O red blood cells, universal donor blood, usable immediately, and 4 units of AB or A plasma. That's the initial cooler, a rapid first response.
And if more is needed.
If more blood is needed, additional coolers with plasma, platelets, and red blood cells, often in that crucial 1.1.1 ratio, or even whole blood where available, are dispatched quickly. Without waiting for individual lab results to guide each step, it ensures rapid, organized access to exactly what a massively bleeding patient truly needs, bypassing delays and giving the patient the best chance for survival. 4. The future of resuscitation, beyond today's capabilities.
Given the inherent limitations of traditional blood transfusions, issues like supply, storage, compatibility, disease transmission risk, there's been this long and intensive search for blood substitutes that can effectively carry oxygen. How has that research progressed over the decades, and what significant challenges have they faced?
Yeah, the quest for an ideal blood substitute, it's decades old.
Okay.
It goes back to the 1920s. The ideal substitute, the wish list, delivers oxygen efficiently, universally compatible, few side effects, prolonged storage, persists in circulation long enough, and ideally cost-effective.
The Holy Grail.
Pretty much. Early research focused on hemoglobin-based oxygen carriers, HBOCs, usually obtained by lysing or breaking open red blood cells. However, free hemoglobin, just floating around, proved to be surprisingly toxic.
Toxic how?
It caused osmotic diuretic effects, leading to fluid loss, significant renal toxicity, kidney damage, coagulation abnormalities, and most notably, it caused profound vasoconstriction clamping down of blood vessels by scavenging nitric oxide, a crucial molecule the body naturally produces to relax blood vessels and regulate blood flow.
Ah, so it messed up blood pressure regulation.
Big time.
Have any of these second-generation blood substitutes made it to extensive clinical trials? And if so, what were the outcomes given these challenges?
Yes, second-generation HPOCs like Hemocist and Polyheme, which were designed to be pathogen-free, universally compatible.
Yeah.
They did advance to large-scale clinical trials. However, the Baxter trial for Hemocist was terminated early. Why? Because the patients who received the test product had a significantly higher 28-day mortality rate compared to those who got normal saline.
Ouch. Not good.
Not good at all. Polyheme, while it did allow resuscitation without stored blood and showed comparable 30-day mortality, unfortunately showed an increased incidence of serious adverse events, specifically myocardial infarctions, heart attacks.
So despite their initial promise and the urgent need for them, significant side effects, particularly that vasoconstriction problem, remain a major hurdle that seems really difficult to overcome.
Correct. A meta-analysis of 16 HPOC trials, including 4 trauma trials, showed a significantly increased risk of heart attacks and death in HPOC patients compared with controls, primarily due to that persistent problem of vasoconstriction. While they might hold potential for specific austere situations where traditional blood isn't available, remote rural areas, combat environments maybe, due to their universal compatibility and long shelf life, that problem of uncontrolled vasoconstriction has remained a formidable challenge. Third-generation products, like liposome-encapsulated hemoglobin, are still in preclinical testing, trying to overcome these fundamental deficiencies and find a way to safely deliver oxygen without causing these side effects.
There's another class of potential blood substitutes called perfluorocarbons, or PFCs, which brings to mind those incredible, almost sci-fi images of mice breathing liquid. How do these work, and what's their current status in medical development?
Ah, yes, the PFCs. Fascinating compounds. They are biologically inert, essentially similar chemically to Teflon or Gore-Tex, meaning they don't react with the body's systems. They have this remarkable ability to dissolve large quantities of both oxygen and CO2, far more than water can.
Right.
That iconic image of a mouse completely submerged in liquid PFCs and breathing, captured back in 1966, truly captivated the scientific and public imagination. Suggested a whole new era of oxygen delivery.
So if they can carry so much oxygen, why aren't we using them clinically as blood substitutes today? What are their limitations?
Well, they face 2 major challenges for clinical use as blood substitutes.
Yeah.
First, they're immiscible in water. They don't mix with blood, so they have to be suspended as microscopic droplets using emulsifying agents, which adds complexity and potential side effects from the emulsifiers. Second, and crucially, unlike hemoglobin, the oxygen dissolved in PFCs has a linear relationship to the partial pressure of oxygen. Hemoglobin has that nice S-shaped curve that helps it pick up and drop off oxygen efficiently. PFCs don't.
What does that mean practically?
It means they require a very high inspired oxygen percentage, often 100% oxygen, to effectively carry and offload oxygen to tissues. Second-generation products like oxygen initially showed promise in reducing transfusion needs in non-cardiac surgery, but were ultimately halted due to serious adverse events, including a possible increase in strokes. Overall, PFCs just haven't proven efficacious for oxygen delivery with consistently acceptable side effects in clinical trials.
With the growing recognition that our currently available artificial fluids aren't perfect blood replacements and can even be harmful in large amounts, what new novel fluids are actively being explored for future resuscitation, beyond just HPOCs and PFCs?
Well, the ultimate goal, though likely decades away, is the development of a truly artificial whole blood, maybe even manufactured from stem cells and bioreactors. That could revolutionize transfusion medicine.
Wow.
But in the meantime, research focuses on incremental improvements and new approaches. Novel crystalloids that are more physiologically balanced than saline or LR. Hypertonic solutions that have better intravascular retention, hypertonic colloids, and critically, new forms of plasma.
And what about dried plasma? It sounds almost like a blast from the past, like something from an old war movie.
It is, in a way. Dried plasma was actually used extensively during World War II, great for portability, storage in the field, but it carried a significant risk of hepatitis transmission because back then it wasn't screened for viral pathogens.
Right.
However, with modern pathogen reduction technology and vastly improved manufacturing techniques, research into freeze-dried plasma, or FDP, has been enthusiastically resurrected.
What are the advantages now?
Key advantages are a very long shelf life, no need for refrigeration, and no thawing time like fresh frozen plasma, which greatly simplifies logistics, especially in austere environments or ambulances. Animal studies have shown FDP to be as efficacious as thawed plasma, It's currently available in Europe and Africa, though not yet FDA approved in the US.
And other dried components.
Yeah, there's exciting parallel research into freeze-dried red blood cells and platelets too, with the ultimate goal of having fully reconstitutable whole blood from these dried components, available anywhere, anytime. That's the dream.
Instead of just replacing volume, are scientists looking at pharmacologic agents, actual drugs, to make the body itself more resilient to the profound stress of shock? This sounds like a truly revolutionary approach, treating the underlying cellular damage.
Yes, this is indeed a profoundly revolutionary area of research, sometimes called promoting a pro-survival phenotype. The idea is, since patients respond unpredictably to shocks, some recover fine, others develop multi-organ failure despite similar injuries. Maybe we can use drugs to influence epigenetics.
Epigenetics, meaning...
Right. How genes are expressed without altering the underlying DNA sequence itself. The goal is to create a more resilient cellular and systemic state using drugs.
What are some concrete examples of these promising agents that are being investigated?
Histone deacylase, or HDAC, inhibitors are showing tremendous promise. One example is valproic acid, or VPA, which is actually already an approved anticonvulsant medication.
Okay.
In swine experiments, VPA treatment without conventional fluid resuscitation or blood transfusion significantly improves survival after severe hemorrhage, like 86% survival compared to only 25% in controls.
Without fluids or blood, how?
These drugs appear to rapidly activate cellular mechanisms to create this pro-survival state, essentially preparing cells to withstand extreme stress. This approach is incredibly appealing for logistically constrained environments like pre-hospital care or the battlefield, where complex medical intervention isn't always possible immediately.
Any others?
Estrogen and progesterone are also being investigated for their anti-inflammatory and antioxidant properties, though human trials in traumatic brain injury haven't consistently shown definitive efficacy yet. But the field is very active.
This is perhaps the most futuristic concept we'll discuss today. Suspended animation. What is the military's interest here, and how does it tie into saving lives in critical scenarios?
Right, suspended animation. Repairable torso hemorrhage, severe bleeding in the chest or abdomen remains a major cause of potentially preventable death, especially in the battlefield or after major civilian trauma where transport times are long.
Okay.
The military has actively supported research into suspended animation, with the profound goal of chemically or thermally inducing a state where metabolism slows significantly, effectively suspending life or putting the body on pause long enough to transport critically injured patients to surgical facilities and repair their injuries.
So the idea is to mimic the natural processes of hibernation in animals or something similar.
Exactly. Research has looked into natural hibernation inducers from animals like squirrels, which can chemically signal cells to dramatically decrease metabolism, slowing heart rate, breathing, seemingly suspending life without causing damage.
Fascinating.
Similarly, animals highly tolerant of ischemia, like diving seals, or those that naturally hibernate in the cold, provide valuable clues about how human life might persist without oxygenation at the rate we're used to. While this fascinating area should help us understand life at the cellular level, the clinical use of hibernation inducers in humans for prolonged periods is, well, many, many years away.
So for now, the more immediate approach is extreme-induced hypothermia to buy critical time for surgery.
Precisely. While spontaneous hypothermia in trauma is generally detrimental, indicating shock, worsening coagulopathy-induced hypothermia, carefully controlled, can be profoundly beneficial. Profound hypothermic arrest, where the entire body is cooled to very low temps, maybe 10, 15 degrees C, using cold, potassium-rich fluids. It's actually already used for short periods in complex heart and brain surgery.
To allow for operating on a still, bloodless field.
Yeah. Exactly. The research in suspended animation aims to extend this to whole body, longer duration suspended animation, ideally allowing surgeons to repair major vascular injuries in an asanguineous state, meaning with no blood loss during the repair itself, effectively pausing circulation, and then rewarm the patient.
This truly raises an important question. If future medical advances allow us to chemically or thermally pause life, effectively buying precious time for healing, what does that mean for our fundamental understanding of consciousness, the very boundaries of life itself? And what new ethical frontiers will such incredible power open up? Perioperative fluid management and electrolyte balance. Shifting now from acute life-threatening shock to more, let's say, daily patient care, particularly for those undergoing elective surgery or managing chronic illnesses. How do we approach fluid management in the perioperative period outside of immediate massive resuscitation?
Right, the day-to-day stuff. The human body is mostly water, 50-70% of total body weight, residing in those intracellular, intravascular, and interstitial compartments, constantly shifting, interacting.
Okay.
For elective surgery, patients are typically made NPO nothing by mouth beforehand, mainly to prevent aspiration during anesthesia. But it's important to remember, we're all NPO when we sleep, right?
True.
And we don't typically wake up hypotensive or in acute renal failure. So for many patients undergoing short elective procedures, aggressive IV fluids the night before or even immediately pre-op aren't strictly necessary. They'll get plenty during the operation itself.
But a maintenance fluid drip is still customary in most hospitals, right?
Right.
What's the rationale behind the standard fluids used for daily maintenance, and are they always ideal?
Yes, a maintenance drip of crystalloids is still customary in many settings, mainly to provide water and prevent dehydration from insensible losses and lack of oral intake. There are established formulas to calculate rates based on weight, like the 4-2-1 rule.
And the standard fluid?
The common standard is often 5% dextrose in half normal saline with 20 millicube per liter of potassium, D5.5 NS with 20 K.
Oh.
However, the exact rationale for this specific formulation is often unclear. And for an average 70 kilogram NPO man, this formulation often provides highly inaccurate and, frankly, excessive amounts of sodium and potassium compared to actual daily physiological needs.
How excessive?
For example, it would provide about 11.8 grams of sodium over 24 hours, when the average daily need is closer to 2 to 4 grams. It's way off.
And what about the historical obsession with urine output as a primary guide for fluid administration? Was that always a reliable indicator?
Urine output. Historically, yes, surgical residents were often rigidly mandated to ensure a certain urine output, often 0.5 milli/hour, probably to build in a safety margin, avoid renal injury.
Makes sense.
But while low urine output can certainly signal a need for more fluids and indicate hypovolemia, aggressively giving large fluid boluses like a 1-liter bolus of crystalloids for minimal drops in urine output can easily lead to rapid overhydration. Our kidneys are incredibly adept, incredibly resilient at protecting us from fluid mismanagement. They can concentrate urine effectively even with mild dehydration. Overhydration, once often seen as harmless, is now recognized as problematic,
Leading to
serious issues like ventilation problems from fluid in the lungs and intra-abdominal hypertension from widespread swelling, or anasarca. Anasarca, that generalized swelling, which was often dismissed as just cosmetic, is now known to be a significant marker of dangerous fluid shifts and complications.
So maintaining fluid balance is clearly an incredibly nuanced challenge, especially in critically ill patients who are fighting multiple battles.
It truly is, and it demands constant vigilance. ICU patients especially can be a particularly challenging group. They could appear overloaded by many liters based on the fluid input charts, even look visibly swollen, yet still be intravascularly hypovolemic.
How can they be both swollen and dry inside?
Their blood vessels don't have enough fluid circulating. This paradox is often due to a systemic inflammatory response like from sepsis or major surgery that causes fluid to leak from the blood vessels into that interstitial space, leading to profound tissue edema, the swelling you see.
Okay.
So clinicians must gather all available information, biokeratinin ratios, urine output trends, vital signs, the presence of anasarca, to estimate a patient's true fluid status, and recognize that normal lab values may not apply during acute illness. It's complex detective work.
Let's finish with a deep dive into electrolytes, these tiny titans that orchestrate so much of our body's function. We'll start with sodium, often called the dominant player in water movement.
Sodium, absolutely vital for maintaining cellular homeostasis, regulating fluid balance, and for generating those cellular action potentials, the electrical impulses driving nerve and muscle cells. It is, as you said, the predominant molecule controlling water movement in and out of the vascular system and between compartments.
In imbalance.
Hyponatremia, low sodium, and hypernatremia, high sodium, are common problems in surgical patients. Mild forms are often asymptomatic, subtle. But severe imbalances can cause significant neurological symptoms: headaches, lethargy, confusion, seizures, even coma. Critically, these always require a blood test to diagnose. The symptoms are nonspecific, can mimic many other conditions, leading to diagnostic confusion.
What are some of the key causes of hyponatremia that surgeons and critical care specialists frequently encounter?
Hyponatremia is often iatrogenic, meaning caused inadvertently by medical intervention, typically from excess intravenous water, especially with hypotonic fluids like D5W.
Okay.
But it can also be commonly caused by pathologic processes in the brain or lungs, like syndrome of inappropriate antidiuretic hormone, SIADH. A crucial distinction is transitional hyponatremia.
What's that?
That occurs due to severe hyperglycemia, high blood sugar. The high glucose levels pull water out of cells into the extracellular fluid, diluting the serum sodium without a net change in total body water. It's a dilution effect.
Got it.
Beyond that, causes can be renal impaired excretion from kidney failure, problems with ADH regulation, or extrarenal, like significant fluid losses from wounds, burns, severe GI issues like vomiting or diarrhea. Interestingly, the body's powerful drive to preserve intravascular volume through ADH release can sometimes override the normal response to hyponatremia, making diagnosis complex.
And you mentioned cerebral salt wasting.
Yes, a particularly challenging condition is cerebral salt wasting syndrome, seen in brain-injured patients. The body inappropriately loses massive amounts of sodium in the urine, despite needing it. Very difficult to manage.
And what about hypernatremia when sodium levels are too high? What are the dangers there?
Hypernatremia usually indicates a deficit of total body water relative to sodium. It leads to dehydration, as water is pulled out of cells, notably causing cerebral cells to contract or shrink.
Ooh, shrinking brain cells sounds bad.
Not ideal, no. While severe hypernatremia can be detrimental, causing similar neurological symptoms as hyponatremia, recent experience with therapeutic hypertonic saline for conditions like traumatic brain injury has shown that acutely elevated sodium levels can be relatively safe when managed appropriately.
And treatment.
Treatment depends on the patient's volume status. Isotonic fluids like normal saline for hypovolemic patients, free water replacement with hypotonic solutions for non-hypovolemic patients, and diuretics for hypervolemic patients who have excess total body water and sodium. The rate of correction is absolutely crucial.
Why?
Generally no more than 8 millieq per day correction to prevent the dangerous complication of cerebral edema where the brain swells as it takes up water too quickly if you correct the sodium too fast.
Okay. And DI.
Diabetes insipidus, DI, a condition of inadequate ADH, causes excessive dilute urine output leading to hypernatremia. It's specifically treated with desmopressin, a synthetic ADH.
Moving to potassium, the main intracellular ion. What are the dangers of its imbalance, whether too high or too low, especially given its tight regulation?
Right, potassium. Normal serum potassium is incredibly tightly controlled, around 4.5 millimoles per liter. Even small changes in serum levels can reflect large intracellular shifts and lead to significant morbidity, even mortality, due to its profound effects on cardiac and neuromuscular function.
Let's start with low potassium.
Hypokalemia. Low potassium, below 3.5 millimole, causes generalized weakness, ileus, bowel paralysis, and dangerous cardiac arrhythmias. You see things like U waves and prolonged QT intervals on the EKG, which can degenerate into ventricular fibrillation.
What causes it?
It can result from renal losses, like with diuretics, or gastrointestinal losses, vomiting, diarrhea, or intracellular shifts caused by medications or hormonal imbalances. Critically, and this is a key clinical pearl, low magnesium can cause refractory hypokalemia, meaning the potassium levels won't normalize no matter how much potassium you give until the magnesium level is also corrected. They're linked.
In hyperkalemia, when potassium is too high, how does that present? And what's the most immediate danger?
Hyperkalemia. Potassium above 5.0 millimole L, with levels over 6 being particularly dangerous. The most common cause in hospitalized patients is renal failure, as the kidneys are the primary route of potassium excretion.
Okay.
Cellular injury from conditions like sepsis or ischemia-reperfusion can also release massive amounts of intracellular potassium, overwhelming the kidney's ability to clear it. The primary, most immediate concern with hyperkalemia is lethal cardiac arrhythmia.
What are the signs?
Often heralded by characteristic peaked T waves on an EKG, progressing to widening QRS complexes, and ultimately ventricular fibrillation or systolic cardiac arrest.
How do you treat it urgently?
Immediate intravenous calcium is the first line of therapy. Not to lower potassium, but to stabilize the heart, protect the cardiac cells from the high potassium. Then you use things like insulin glucose or sodium bicarbonate to shift potassium back into cells, temporarily lowering the serum level. For severe cases, especially with renal failure, hemodialysis is the most reliable and rapid treatment to physically remove potassium from the body.
Lastly, calcium. Crucial for so many body functions, including coagulation, as we discussed earlier. What are its key roles and the implications of its imbalance?
Calcium, most abundant electrolyte in the body, Absolutely critical for coagulation, neuronal function, muscle contraction, bone health. We primarily monitor ionized calcium, the biochemically active form, not just total calcium, which can be thrown off by albumin levels.
And low calcium.
Hypocalcemia, low calcium, can be life-threatening, causes symptoms ranging from paresthesias tingling, numbness and muscle spasms, like Schwastick's or Trousseau signs, to more severe things like seizures, laryngospasm, and dangerous cardiac dysfunction, including the prolonged QT interval that can progress to complete heart block.
What causes low calcium?
Causes range from hypoparathyroidism, often seen after central neck surgery where the parathyroid glands get accidentally injured or removed, to tumor lysis syndrome, where rapid cell breakdown releases phosphate that binds up calcium.
Conversely, hypercalcemia.
High calcium. Hypercalcemia. High calcium. Most commonly caused by hyperparathyroidism or malignancy. Symptoms include weakness, confusion, polyuria, frequent urination, constipation, kidney stones. Severe cases can progress to a hypercalcemic crisis, leading to lethal arrhythmias. Treatment involves addressing the underlying cause and managing symptoms with fluids, diuretics, and specific medications like bisphosphonates or calcitonin.
And finally, magnesium. Often overlooked but plays an incredibly critical role, sometimes even influencing other electrolytes, as you mentioned.
Magnesium, yes, primarily an intracellular electrolyte. Its plasma levels often don't accurately reflect total body stores because most of it is inside cells or tied up in bone.
And low magnesium.
Hypomagnesemia, very common in ICU patients. Prevalence rates range from 11% to a staggering 65%. It can cause life-threatening arrhythmias, particularly a specific dangerous type called Torsades de Pointe. And as we said, it's a known cause of refractory hypokalemia. Got to fix the magnesium to fix the potassium.
And high magnesium.
Hypermagnesemia. Though rarer, it's often iatrogenic, caused by medical interventions, frequently stemming from excessive magnesium-containing drugs, like antacids or laxatives, especially in patients with renal impairment who can't clear it.
What does high magnesium do?
It can lead to neuromuscular toxicity, flaccid paralysis, and significant cardiac issues like bradycardia, hypotension, even complete heart block in extreme cases. Disorders of magnesium homeostasis are often unrecognized in critically ill patients, underscoring the vital need for routine monitoring. Both extremes can have dramatic, life-threatening effects. Outro.
Wow. We have taken an incredible deep dive today. I mean, from the almost unbelievable 17th century resuscitation of Anne Green
Still shaking my head at that one.
to the cutting-edge science of pharmacologic agents and even the, well, frankly futuristic concept of suspended animation. It's abundantly clear that managing shock, fluids, and electrolytes isn't just some routine medical task. It's an ongoing scientific, historical, and deeply complex journey.
We've seen how painful lessons from wartime have profoundly shaped our understanding. How seemingly simple solutions like normal saline have hidden complexities, hidden detriments we're only now fully grasping. And how our understanding of molecules like lactate has completely transformed from simple waste product to vital cellular messenger.
Yeah.
It truly highlights the dynamic, often paradoxical nature of the human body and just how much more there is to learn and discover. We're still just scratching the surface in many ways.
And it raises an important, perhaps even profound question for you, our listener, to mull over. If future medical advances truly allow us to chemically or thermally pause life to facilitate healing, effectively buying precious time, how might this fundamentally redefine our understanding of consciousness, the very boundaries of life itself? And what new ethical frontiers will such incredible power open up for humanity?
A lot to think about there. Thank you for joining us on this deep dive into the fascinating, intricate, and often challenging world of fluid and electrolyte management.
We really hope this deep dive has given you a profound appreciation for the science behind saving lives and maybe left you with a lot to think about. Until next time, stay curious.